Hey Alexis, I see you on. Can you test your mic just because I want to make sure everybody can hear you today?
Yeah, can you hear me okay?
Perfect. Thank you, my
Awesome.
friend. You're about halfway through, and I'll have you jump in when we get to your slides, okay?
Sounds good.
All right. Thank you for joining us. Welcome to the February Learning Forum for Champs Only. I'm going to continue admitting folks as we get going here, and I'll just turn it over to Tara to get us.
Hi, everybody. Welcome to February Champs Only Take Two Learning Forum. We found it extraordinarily helpful for us to just huddle with you all last month, and so had planned purposefully 2 months in a row of just going through questions, updates from you all, and talking through some hard pieces of this bundle. The truth of the matter is, you all are really, really working fast and furious to update your uh, timely treatment protocols. You're submitting data to us. You are working on transfer protocols, and in the middle of that, somewhere is patient care. So just know that we appreciate you very much. As a reminder, and I see that Tiffany put that there, guys. You're recorded. If you do not want to be recorded, you do not want to be in the session. You have every right to not be here. We just want to make sure that that's clear that you're recorded. And you guys, because we're kindergartners and I have to take attendance, I want to know who's here. Please put your name and your agency. Dana knew what I was going to say and read Tiffany's note. Put your name and your hospital in that chat sheet or chat area for me. Welcome. How you doing? I cannot wait to see you all in May. We will talk about that just in a second, but I miss you all. I get great bucket fill moments from seeing you all in person, but I really, really appreciate the emails and the phone calls that I get from you all too. Um, um, Patient care is the most important thing, and hearing stories across the state is part of what the gift that you all give me is the picture that you or the pictures that you see in front of you were because I was watching the Olympics, as I'm sure many of you were, and it kept hitting me over and over and over again about the tremendous story of the moms behind the medals, the moms of the Olympians. And that's why I put that picture with Snoop Dogg because he's certainly a story of moms too, somehow. But regardless, the story of the Olympics was part of our story. You've got women that are birthing babies with special needs. You've got women who are somehow finding time to do this in amongst caring for patients. You've got all the stories. And so um, every birth means something. And the Olympics is a huge scale of that, but also it's not lost on me that we're doing important work, you guys. Next slide. Nikki sent this to me, and I really appreciate it. I can't remember what weekend it was, but I got on the treadmill and I looked at my phone and I had received this from her, and I thought, man, what a great visual. It goes back to the first trimester initiative conversation a bit, but isn't it a poignant visual? Prenatal visits, look at those numbers. Infant visits, I'd say that's an underrepresentation, but look at those numbers. Postpartum visits prior to the fourth trimester in initiative in Kansas, maybe one. So you all have upended that rule. You've flipped the box. You've added many hashtags, including those with severe hypertensive illness and pregnancy, and you are changing the dynamic of healthcare in our state. Next slide. So, speaking of seeing you all, May 1st is our in-person. We're calling it a work day, which shouldn't be intimidating. It's actually a really great brainstorming session in the afternoon. But look at the topics that Carrie and I have for you in the morning. We'll kick it off at 9 o'clock that morning, go to lunch with three really important separate topics. Break for lunch, celebrate the successes of everything back from NAS for a trimester, and then our current severe hypertensive bundle with a special presentation. And at 1 o'clock, we will have breakout groups and deep dives into those pieces of the bundle that are most vital to get done. Don't blink, guys. This bundle is going to be over and completed and successful very soon. So we will work the afternoon together. But the morning, we are excited to announce that we have a panel discussion, three experts coming on pediatric and maternal vaccines. And if you haven't looked at the news today, you should. ACOG just pulled out of the CDC committee regarding vaccine decisions across the nation. Big mic drop moment. So regardless, it's more than a hot topic for maternal vaccines, but regardless, pediatric and maternal vaccines, we're excited to host that panel. 10:15, the untold story. We have a great physician lead in our state coming to talk about peripartum cardiomyopathy and the other associated cardiac risk factors. The no way is she that unhealthy moment, right? And she just had a baby. There's no way this could be a cardiac event. And in fact, it is. So really excited for that. And then at 11:30, a wonderful lived experience. Really excited to announce this formally in the next week or so. You'll be thrilled to hear from a patient herself and excited to share more as it comes. So for now, we need you to register. We will send out more information in the next week, but we will have you send one champion or one representative per hospital and a +1 with you. We do have space limited, and we're sorry about that, but we want to make sure every hospital sends at least one, both birthing and non-birthing. So more information to come, but May 1st, we get to see your faces. Next slide. Again, these are just things to have on your radar. We've talked a lot about aspirin therapy. You're seeing it a lot more as patients enter the hospital in the antepartum, certainly in the delivery setting, and lots of conversation about the correct dose and those candidates. Who's a candidate for low dose aspirin therapy for prevention of hypertensive disorder in pregnancy? And the Society for Maternal Fetal Medicine came out with a really great article that talks about risk factors and how to calculate risk factors, who qualifies. This is the article. So the link at the bottom is extensive, but as usual, Tiffany will send that out and follow-up resource list for you all to click through. Really encourage you to share it out with your provider colleagues and your nursing colleagues. Really great up-to-date information there that is being used across the nation. Next slide. Carrie, I think this one's yours.
Yes, another article I wanted to share with everyone just recently published that just shows that severe maternal morbidity is tied to perinatal depression. So another great resource that we will have Tiffany share out after our meeting today. Next slide.
So Carrie finds lots of slides in the middle of the night too, or lots of articles in the middle of the night, and I'll wake up to these great the fuel for thoughts. I bet you guys do it amongst your colleagues too, and you're like, oh my gosh, have you seen the latest data on ... And so I love those from Carrie. That article is legit. You guys should take a look at it. It ties in the maternal mental health to the prevention of severe morbidity, and it's an aha moment we all kind of knew about. Just it's interesting to read it. If you have not seen the updated medications and lactation PDF resource put out by our friends at the KBC, Kansas Breastfeeding Coalition, you're missing out. It's been a thing for a while, but they did a huge update and how vital and helpful this algorithm and links to other resources. And you can see them kind of small there at the top of that picture of the flyer. Regardless, the link is also embedded. Again, Tiffany will send it out again with the resources. It's also on our website, kansaspqc.org. I will tell you that our KBC team will be in person in May at that May 1 event, and we'll be talking about pumping and hand expression protocols for questions or concerns or we're stuck moments. But also we're going to expand the conversation, and there's a work group specific around this idea, medications, and what really is the answer to is it safe in nursing or not, but also to take that a step further and other medications and the fear of some medications and their use in lactation, centering around substance abuse disorder, maternal mental health, et cetera. So that team's working hard for you all. We want it to be easier to make decisions and to educate families. We're excited for that. Next slide. I think Michelle Black is on the call. And if she is and she has anything specific to say, it's just a reminder you guys, well, hi, Michelle. The data collection piece was due February 4th. I know Carrie has reached out to some of her sites. I've reached out to some of the sites assigned to me. but it doesn't matter who's assigned to you. We just want you to submit your data. And you guys, we know that there's some really hard pieces of this, the disaggregated data, numerator, denominator pieces, some of those. And please don't let that stop you. Reach out to Michelle or Carrie or I today, and just say, here's where I'm at. Here's the data I've got. This is what it is. Or I'm stuck, or I have a question, or I'm not sure. You would not be the only one, two, or 20th that had questions, and yet we want your data. We know what you're doing. We know how good you are at your work, and so we want to see that happen. Um, Next slide. So in terms of an update on who has submitted essentially the second half of 2025 data, we've got 28 of 50 hospitals. So over half have now submitted your data. Thank you, thank you. Those that are listed here are the ones that have submitted. If your hospital is not here and you have submitted data, please reach out to Michelle. But if you're not listed here and you're stuck or have a question, again, reach out to Carrie and I. I will also tell you that one of the things that we are missing very, very, um, or we need very quickly are your birth numbers from 2025. So part of that data collection is that we've got to get the birth numbers in ASAP for some of our reporting. And it's one of the reasons we're kind of nudging you today. Next slide. Again, a reminder, we're done at the end of the year with this bundle. It doesn't mean that we will continue work and we will continue to be helpful to all of you to keep the bundle work going. But we want the QI pendulum moved. We want the protocols completed. We want timely treatment to be the standard, et cetera. And the end of this year is it. So it's time for us to start planning the next safety bundle. And we absolutely respect and appreciate your input in that decision. And so many of you have already submitted it, which is phenomenal. Thank you. If you have not submitted your bundle survey for choosing the next safety bundle, please fill that out and send it in ASAP for us. Carrie,
That
anything else?
email, yep, I
Yeah.
was just going to say that email went out yesterday, and I'm excited that in the first 5 hours of that email going out, I had 17 replies back from you all. So that is amazing. Thank you to those of you who have filled it out, but we want to hear from everyone. So please look into your inbox from yesterday, find that email from us from KPQC directly, and let's get that filled out. It shouldn't take you more than 5, 6 minutes to do so.
Awesome. Carrie, I just saw your text. Hey, Carrie is running out of charge battery, and I don't want you to die. I would love for us to talk about those end slides and we can come back to this. Carrie, is that okay with you? We
I'm
jump
totally
forward?
fine with that. I
Yep.
am desperately seeking out a place to plug in my computer right now, and there's 10,000 people around, so they're all hogging them. I apologize. But yes, let's talk about
Let's go to 15. Can we go to slide 15, Tiffany, and we'll come back to this.
You'll have to tell me when to stop. They're not numbered.
Right there. Right
Okay.
there. So, oh
okay.
yeah. Sorry,
Yeah.
Tiffany.
If you haven't already done so, please send me your, we've been saying breastfeeding or pumping protocols, and I think it may have caused some confusion that people thought that they had to have a completely separate pumping protocol. It can be embedded in your breastfeeding protocol. It can be embedded in your care of the neonate protocol, whatever, just as long as it gives guidance to ensuring that we have that mom initiating pumping within 3 to 6 hours after delivery in the instance where she has a newborn who's going to NICU, special care nursery, being transferred out of the hospital for any reason. We have to make sure we're doing that mom justice and getting her pumping. Next slide, please. And I do believe I have a list. Here's in honor of Tara talking about the Olympics, here's my gold medal for those of you who have already submitted it to me. So I think you get a good shout out for being on top of it. If your name's not on this list, you owe me a protocol. If you need help with it, and that's what's caused your barrier to getting it to me, please reach out. I can definitely help with that. Next slide, please.
So this is Alexis. Carrie, let's pop forward to your Tiffany, I can help you. You're probably about 10 slides away from where we need to be. It's about the protocols. Keep going. Keep going. Right there.
Okay.
Carrie. Yep. One back. Yep, right there.
Yep, perfect. Okay, so we've been talking since the initiation of this bundle that we would include ensuring that every facility has access to or an updated version of a transfer protocol. And we keep saying, stay tuned, stay tuned. So here we are. Here are the components that we're looking for in a transfer protocol, making sure that we've identified the need for transport or transfer out of your facility, that you have acceptance from an accepting facility, that there is some transfer care policy, including documentation of timeliness. So let's give you a little bit more detail about what that means. I am a hospital who cannot care for this, whether I'm a non-birthing hospital or I'm a hospital who needs to send this patient to a tertiary care center, a higher level of care that she needs. If she has treatable blood pressures, have we treated them to ensure that we've started that ball rolling while we're in the process of transporting her out of our facility? What are you doing to tend to her at the same time that you're trying to get her out the door to that next level of care? Making sure that you have guidance for your staff that governs what does that look like, who are the facilities that you have as options, and what does it look like to have that acceptance from that facility? Does it dictate provider to provider communication, ensuring that there's a handoff or acceptance from one physician or provider to another? And then ensuring who is it that you're reaching out to for transport? Is it your local EMS? Is it a county resource? Who is it that you're reaching out to for transport? Do you have anything to add to that, Tara? Okay, perfect. Next slide, please. You can move past this one. Y'all are doing a great job getting, I feel like I'm just driving down the protocol message today, which sounds like a lot when I'm doing it one after the other. So I'm nagging you and I apologize, but these really are the fundamental like foundation of this bundle, you guys. You have to have something that guides the next caregiver, the next clinician on what they need to be doing. So making sure that you guys are getting those hypertension protocols to me if you have not already. And then making sure that you're talking about the importance of timely treatment. It's a measure that we are collecting for data. And what is the criteria for that? Just remember the criteria is that you have two readings 15 minutes apart, where systolic or diastolic is over 160 or over 110. Then they qualify for the timely treatment protocol. I know there's been some confusion when we've talked to different facilities that do I have a fallout? And making sure that you truly understand what the measure is, what the criteria is for that, so that you can accurately collect data. I want this to be a conversation too. So while we're on this slide, are you guys finding any barriers to getting your protocols done, or any barriers to being able to accurately collect the data and meeting this criteria? And timely treatment, we can definitely cover that as well. So I kind of want to open up discussion on this slide on whether or not you guys are up, or what it is actually that you're up against. This is the awkward silence where I will sit and wait. For those of you who have not submitted your policies or protocols yet, any challenges or barriers that you're up against that you are needing help with? I will say it's pretty amazing. Every time we have a meeting and we bring this up, usually within the first 24 hours, I will get 3 to 4 more policies. Cassie, yay, you raised your hand. Go for it.
Hi. So I think something that we're running into is we have a protocol in place, but some of our providers will see someone coming in triage who have two qualifying blood pressures, and they will just order a one-off treatment instead of just initiating a protocol that we have in place. They're like, oh, just treat them with like ×1 PO dose and we'll see how they do. It just always, we're trying to really enforce the protocol with them, because then we end up treating them again later and we don't have it in place, where it's hard to pick where to start on an algorithm based on how many meds they've given outside of that algorithm too. So we're just trying to increase adherence with our provider group.
Love that. And every time you have to start all over, it increases the amount of time it's going to take to treat her, because you have to get an order. You've got to get it approved through pharmacy. You got to get access to the med and the Pyxis, and you got to get a nurse who has time to administer it. So just explaining that component. I don't know, I'm sure you've had this conversation with your providers, but whether or not you have a perinatal safety committee or an OB department meeting or any meeting that you can take it to, that you may have a physician or provider champion that can have that conversation with your physicians. I would encourage that because I do know you are not alone, Cassie. You are not alone with that being a barrier. Tara, any thoughts?
Yeah, Cassie, thank you. That
Yeah.
you're definitely not alone. Can with the raise of hands or in the chat, are there hospitals on this call that have to write up or submit a variance if the protocol is not followed? Is anybody doing that in their facilities? So again, you've got the protocol in place, and an example like Cassie described, is that a write up in any locations with raise of hands or chat? Yeah, KU.
So KU says yes.
That's why I brought it up because I thought that that conversation came up. Key protocol not followed. Okay. Thank you, Chelsea. Tony's doing it there too. I think some will put, here we go. Risk ticket. Becky, I saw you on here. Becky, can you describe what a risk ticket entails? Like what happens next? Somebody's writes a risk ticket and then what?
Let's see. So if we don't follow the standard of care, we submit a risk ticket so that it can be reviewed by peers and providers to see how we can make improvement in the future on the next case.
How long does it
Awesome.
usually, what does that turnover usually look like? Is this like a quarterly review? So something happens and then you have to wait a couple months before someone addresses it, or is it like a monthly committee at your facility?
It's usually bi-monthly.
Okay.
I will say something that we've kind of discussed is our providers don't consider it not meeting the standard of care because they did treat the patient in a timely fashion. And they said that it's at their discretion how they treat or what protocol they utilize. But we have just discussed amongst ourselves maybe taking our KPQC measures to our next subsection and just putting them in front of all of the providers so they are just very aware of what we're trying to address.
Yeah.
Yeah. I
Um,
totally agree with that. And I do think that if you explain to them that you may be treating them initially on that first time, but it could create subsequent delays later on down the road, that maybe that would help too. But I love the idea of taking it to that
well,
meeting.
and Cassie, the reason I brought it up is because I kind of, so this is the whole trickiness, the trickiness and uncomfortable conversation about who gets to tell who what to do. Okay. So I'm preaching to the choir, but at the same time, I would say to you that this is the part where we're champions within the provider group, champions within the hospital to say this is the protocol. And yes, of course, the practice of medicine is absolutely an issue of looking and seeing and doing and responding. Um, what are we going to do to fix it? And I think the data, right, presenting data to them about what happens when you don't do the standardized nationally approved protocol is part of that. But it's tricky. And Cassie, again, I feel for you a little bit. I'm really excited that you guys are keeping track of it. And I know other hospitals are because I've heard that same story from others. But anyway, kudos to you all. Other folks that submit or that review, I saw Kim. I know Stormont does kind of a major review of fallouts, we call them. They do a different dive, but it's very intentional. Anybody else that's chasing this data and again, I don't want to sound punitive. I really
Mm-mm.
don't. Because let's just be honest. I would say even 5 years ago, nobody knew what severe hypertension was defined, like what was the definition. And we were treating people, all over the place. So in some respects, we've come a long way and we want to go further. So any other input or this is what we do, dot, dot, dot. I'd love to hear it.
This is Jessica from Hayes, and we have it's kind of interesting when the information goes into, we call it the Verge system, and they have nursing, it gets looked at from the nursing standard of care and then the physician standard of care. And so like our supervisor would go through to see if the nurses met what they were supposed to be doing. And then look at the physician side of things would get reviewed by like physicians in the hospital. And so sometimes we kind of run into a challenge of, do the doctors above really know what the doctors are supposed to be doing in OB? And so I think sometimes that hierarchy might be a little bit uneducated specifically to what the OB should do. So that's just kind of something we come up against.
Yeah. The QI is there, but the QI may not have a perfect algorithm to it. Yeah, I'm following you.
Mhm.
Who else? Lunch and
Ooh, I do
learns.
love lunch and learns. Yeah.
Nikki, are you able to come off? Nikki, I showed your graphic before I think you got on, and I just want to tell you thank you for that graphic. It was poignant. Are you able to come off?
Yep. Yep.
Oh, hey, Nikki's here.
Hi.
Hi,
I'm sorry I
Nikki.
was late to the beginning. I was in an exec meeting, but
Well,
we
thank you for being here. Yeah, no, tell us
yeah,
your story about Lunch and Learn.
when we started the fourth trimester, I just knew how fast the data was coming, and it's like, how do you really get everyone on board? You can talk about it in your nurses meeting, but that doesn't really seem like it's enough time spent, and you're trying to, train. For me, it's probably 15 nurses most likely that are going to be in OB working, but then you have your provider piece, and I was trying to connect all these different dots, and I'm like, let's just do a lunch and learn and see how it goes. Well, it was fantastic because we can review we reviewed the fourth trimester initiative, all of the stuff that went into that, all the questioning, all of the mental health screening, all of it. So we could review it as a group, put it into practice. The doctors were there hearing, providing their input, and then they've just really taken off from there. So then it's gone on to the hypertensive bundle and how we're looking at that. And we're going over different scenarios and what we would do if in this situation and tying the bundle together in that sense. But truly, I don't really know how else we would have done it without incorporating lunch and learn, just to make sure everyone's on the same page and following the same protocol. And it's really been a way for us to educate the providers, honestly, like on what we've learned through being in the bundles and have them review the data that way. And then it's really made it be very collaborative. And I think that's the key piece for us. And yeah, it's been really good. So
Awesome idea. Thank you for sharing. We can absolutely, and again, this is part of what the in person is about. Is you start to have what we call open mic, and the conversations start to, in a good way, tornado. And so I'm going to let Carrie keep going, but it goes back to the data piece, and please hear us say that we know that there are fallouts, and there are fallouts that just have to be called fallouts, even if you're doing great work. So when you submit data, please don't be embarrassed, or we just want to hear how you're doing and how we can help. And Cassie, you're not in charge of everything. Um, you're in charge of making sure it's moving forward, right? So kudos to your hard work too. All right, Carrie, keep rolling.
Perfect. Next slide, please. My hot list, that's what I'm going to call this, my hot list of facilities that still need to send me over their severe hypertension policies. Again, if there is a barrier to you doing it, if you feel like you've got it started but not completed, please reach out, and I will see what I can do to help facilitate that for you. Next slide, please. Blood pressure appointments. I know there was a lot of conversation that we had back and forth on who's supposed to be going at 3 days, who's supposed to be going at 7 days. What if our facility just consistently does them all at 1 week? Does that count? I'm trying to get a feel for truly how many people are getting those blood pressure appointments scheduled. We don't have all the data in yet. And if you are getting it scheduled, reminding you what constitutes as a visit. So just reminding you that these could be your patients who come in for a breastfeeding clinic, or these could be a patient who's coming in and they're assessing her blood pressure at the same time that she's bringing in the newborn for, a 2 or 3 day visit. Anyway, I'm just want to open that up for conversation too. How is that going for you all getting those scheduled? And are you guys up against barriers with that? I love a good conversation, guys. So tell me how it's going out there.
Hi, this is Michelle from LMH Health.
Hey.
So it's been going pretty well for us. We work primarily with one OB office, and they made it so our patients could schedule their blood pressure follow-ups with a nurse in their portal. So regardless of when they're discharged, because most of our fallouts were falling on weekend discharges, so they weren't getting that appointment set up. So that has helped significantly doing that. Our family practice provider, it's a little harder to track because she does the blood pressure with the infant's 2 to 3 day appointment. So we can't access them through our EMR. They're not employee owned, so it's just a little trickier, but she's active on our perinatal excellence board, that provider. And I think she's pretty diligent at following up with her patients. It's just she does that blood pressure check at the infant visit, but otherwise, our providers are also doing a better job of communicating through their like office communication on the back end to their nurse, just to make sure that patients are coming in and that's not falling in the crack.
Love it. Thanks, Michelle. Thanks for sharing that. Go ahead, Tara.
Yeah, it was just reminding me, we've had a couple of hospitals that have asked about this moment, Michelle, with your primary care or your family practice person. If in their discharge note or order set, whatever it is on discharge, it tells them exactly what day or days to come based on protocol and gives them the information about that, that counts. So I just want to make sure that everybody keeps track of that and consider that a win. I love that you're following it through with checking that it actually happened. That's the next level of expert data. But just know that as long as they're following protocol at discharge and it's documented, you can't just guess at it, right? But if it's documented to be correct at 3 or up to 7 days for that group, that's the 7-dayers, it's absolutely okay. But Michelle, nice work. When there's so many patients and so many different providers and so many ways to schedule, it is hard to chase that. I love the patient directed appointment making. That's impressive work.
It's a great idea. This is a great avenue to be able to share that as well and allow other facilities to take that suggestion back and say, is that something that we can do? So great job. Anyone else want to share?
I have I have a question. When we talk about treatable blood pressures, now, while this patient was here in the hospital, yes, her blood pressures were elevated. We maybe had one severe during her labor and postpartum, but she was started on blood pressure medicine. We think she likely had chronic hypertension because her 8-week initial OB appointment. I don't even want to tell you what that was, a severe at 8 weeks pregnant. So she didn't get treated here because she never met criteria for it, but she went home on an antihypertensive. So she's scheduled 7 days out to see the doctor. So you're going to put that am I putting that into the data or not? Don't you like it? Tara's just shaking her head going, Jackie,
she's like, of course, Jackie. Of course, Jackie threw that in there.
She's like, go back to your Meditech training because that's what I'm doing.
No. I would tell you that I'm scratching my head about her diagnosis and the quote and treatable blood pressure. We can deep dive into that one if it's a single outlier. I think that she got an appointment within 7 days with chronic hypertension, but she was treated in the birth setting, so therefore she's a 3-dayer. But there could be arguments either way. It's a fallout that doesn't make you at less than 90%. So, but bottom line is that the protocol is adjusting for those patients that are diagnosed and treated.
And the good thing is we've been back doing weight checks and belly checks on babies. So, and it may or may not be someone in the healthcare field. And so she's been asked every day that she's come, how are your blood pressures? And when I asked her this morning, she said, I haven't taken it yet today. And I said, I just looked at her.
Yeah. Well, and the piece of this, which you're hearing more and more folks do in small settings and tertiary care centers, is this idea of a postpartum appointment. Remember that? fourth trimester conversation. I think it's happening, but I'm not going to say it out loud too loud, too much. But there is a need for a postpartum appointment, even if it's not with the primary OB provider, as long as the primary OB provider is part of the elevation of care as needed, right? And I'm seeing more and more postpartum clinics and breastfeeding clinics and newborn, and we're using the newborn to get to mom options. So great job across the state with all of you.
Caitlin
Caitlin,
in the chat.
I need my readers. Caitlin, are you
I
able to come
know.
off of mute, or do you want me to just to read it?
I love that. I can tell you what she says. She said we
Yeah,
do what it's called.
sorry,
Oh,
I
good.
got
You
it.
did it. Go
Yeah,
for it.
sorry. Yeah, we do a follow-up regardless of any risk factors. So we see all of our moms and babies 2 to 3 days after going home. And it's just a general assessment on both of them. So if we catch anything, we can get a hold of the provider from there.
I love that.
Caitlin, who hosts that? Is that your inpatient or outpatient group?
It's so we only staff 2 nurses on our floor, so it's
Yeah.
all of us. Yeah.
Yep. Yep. Yep.
Yep.
Nope. Totally makes sense. I just want to make sure
Yep.
I'd asked. Great job.
Yep.
Okay, Tara, my computer's going to die in about 2%. So
I wanted to
if
watch
that
you like
happens,
lose your, yeah,
yeah,
does that happen? Do you like
it
lose
just
your,
went into battery saver
oh
mode.
God,
So
oh
we'll see
God.
what happens.
She's on the way
Um,
out, guys. Give her
yeah,
bed. I gotcha. I gotcha. Okay. I think I would like us to go back to Alexis's slides.
perfect.
You guys, gosh dang. Um, again, you all know that the dynamics of birthing persons is not just severe hypertension or breastfeeding or um, maternal mental health, but in fact, it's all things about that patient. We also know that when she has an amplification of a complication, aka severe hypertensive disease in pregnancy or postpartum, that immediately her SSDOH needs amplify and become more obvious, right? So let's just remind ourselves that maternal mental health scores for the patient volume or patient cohort that we're looking at right now in this bundle are hypertensive patients. Their maternal mental health needs, remember that article that Carrie just talked about, are exponentially higher. And if we ignore this in the moment, you treated a blood pressure and forgot the other 99% of the patient. So Alexis is here to talk to you all and remind you all about the good work that KCC has done with this group. We have combined efforts with the KPQC for lots of years now, and they are a phenomenal resource. You guys are so busy that we didn't want to just hound you with emails. And so Alexis said, hey, I'll come on and just remind them of our availability and what we'd like to hear from the next with. So Alexis, you're on.
Hi, everyone. So hopefully most people on this call are familiar with KCC at this point, Kansas Connected Communities. We've been working with the KPQC since the fourth trimester initiative. And I know we've done a lot of individual TA with different sites to address different concerns for different implementation of screening, referral and resource network building. But we just wanted to remind you that we're still here, we're still a resource. And so this is just a brief overview of our services. We are the perinatal psychiatric access program for the state. So you can call our access line Monday through Friday, 8 to 5, if you have a patient case where you are needing support, whether that be with medication management, if you need resources for a specific case, if you're looking for therapy, recommendations, any of those things, feel free to call our line and they will direct you to the appropriate resource if they're not able to address it, or we have our perinatal psychiatrist and an OBGYN that additionally staff that line that can help you. We can go to the next slide. And this is our number that you can call. There's also an online form that you can submit to submit those concerns. And like I said, that's 8 to 5 Monday through Friday that you can access those services. And additionally, through our program, we do technical assistance, which is what I'm here to talk about today, and then different trainings that we offer. I think a lot of you received information about the Bridges to Wellness training that we did back in October, and that was with the IPV specialists as well that we work with. And so just the overlap of those things with interpersonal violence and maternal mental health, and just the importance of being able to address those things in conjunction with each other, especially in the perinatal period. So we can go to the next slide. And so we have developed just knowing that there's a need for providers that we work with for technical assistance. And sometimes it's hard to schedule. Sometimes it's hard to know in the moment that you need that support, but we wanted to make it open and available for people. So we've started doing biweekly office hours on Zoom. And so I will drop the registration link in the chat as well. If you weren't aware of these already, you can also scan that QR code to sign up, but basically it'll be staffed by myself and another member of our team, and you can join. If you have a specific question that you would like addressed, we're happy to go over that with you one-on-one. We can also just chat through specific resources that you would like to learn more about, or a screening tool, for example, a workflow, talking through building out your resources more and referral networks, any number of things. We've been hearing more and more from clinics and hospitals that responding to mental health and substance use needs it's increasingly difficult, especially with maybe you have wait lists for the resources and referral sources that you're sending patients to, and you're struggling to get them that next appointment fast enough. Or you're just struggling in general, maybe based on geographic location. Doesn't seem to be enough resources available for your patients. And so we would like to problem solve and think through some of those things with you, and maybe come up with a workflow or a solution for those things. So we're very happy to work with you. We want you to know that you're not alone in dealing with these problems, and that you're also not alone in feeling that way. We've been hearing that from multiple different sources and different providers. So just wanted to offer that support and let you all know that we are here and we would be happy to work with you. And I think the next slide is just our contact info as well. And I'll also put my personal email in the chat if you would like to reach out to me directly.
Alexis, thank you. I think the most common reach out that I've seen, other than the directional, hey, these are the protocols, or these are the provider resource lines, or here are the education offerings, is hospitals, exactly as you described, will do an Enberg screen, or they'll do their standardized screening prior to discharge home, have a positive screen, and boom, the referral is stuck, right? Who's taking care of the referral? We are screening, but there's no referral, or referral is completed, but no who's chasing the completion. And so Alexis and her team have done a great job of providing hospitals and outpatient clinics and providers and everybody involved with that flow chart. And also, hey, if you are in trouble with resources in your community, here is the statewide hotline. Here are the things that we can do to loop back in. And we just keep hearing the same thing. And I love that we're screening. The problem with screening is, what are we doing with it? And the warm handoff is what Alexis and I talk all the time about. So thank you for your time. You guys don't hesitate to reach out, even if it's just to say, hey, here's where we're at. Any input would be appreciated. So thanks for your time today, Alexis. And you guys, all these slides will come out to you just like they do. So you'll get the slide deck at the end, so that you have Alexis's contact. She's a great resource, as is her team. Let's see, Tiffany, I am not sure. Hey, that's exactly what I expected it to be. The intimate partner violence, horrible segue about a really important subject. Let me not use that tone. Intimate partner violence is extraordinarily challenging in this conversation, because again, if we talk about, I'm picturing, when Alexis was talking, I'm picturing several patients in my head who had a horribly challenging labor, severe hypertensive included. Let's say we put her on MAG. Let's say she ends up delivering by cesarean birth. Let's say that she's 36 and 5, and let's say she's hospitalized for 3 to 4 days for corrective work on blood pressure, and then we send her home. And like, can you picture her, right? You've taken care of her for the last 20 years of your career. And oh, by the way, in the bathroom on day 2 post-op, she mentions to you that things aren't good at home. And boom, what do? Right? So, Jackie, I actually have you on cue here, but we're going to run out of time. I would like for you to tell the story of what you shared with me at the next learning forum. But there are folks like Jackie who find extraordinary moments to use cues training, how we have conversation to everyone about we're here for you. Please tell us how we can help. But guys, we need to really finish up the things that are already happening in your sites with what's called a community partnership agreement. It's just showing what you are doing or helping or letting us help you tighten that up. Meaning, what happens when, or who's your partner in the inpatient to outpatient setting to have available help to these patients? And that patient workflow is a phenomenal resource that's a protocol, right? So the Mavis team created this awesome document. It talks it through like what to do when, and of course, including cues training and work. But that community partnership agreement, we're going to have every hospital that's enrolled complete. It is just an agreement between you all and whoever your IPV group is locally or maybe regionally, and get that tightened up. What we're finding again is that there are disclosures or requests for help, and they were met with no resources. And so the emergency department with a severe injury is where we find out that there is no community partnership. And backtracking and finding records, we find out that she disclosed or she asked for help multiple times, and there was nobody finished the referral. So that's why this is here. So we'll talk more about it. You will see that request come out that's completed. For many of you, that's your social worker, by the way. Most OB departments have a workflow that includes social work or navigation, and that's then referred to the outpatient setting, and that's perfect. We just want to make sure that we tighten that up. Okay. All right. I want to go back to post-birth. Can you go backwards, I think, Tiffany? Watch your eyes, everybody. Right there. Just a gentle reminder, we are encouraging the education of post-birth across the state, point blank. We're providing 2 and sometimes 3 free seats to you guys, and you can use those free seats each to transfer or to educate hundreds more. Really, it's our EDs, our EMS groups, and your outpatient OB primary care walk-in clinics. Guys, everybody needs to know how to respond to the post-birth moment, right? Especially those top 4 letters. We need this done by this summer. Really want to make sure you understand how to use the seats. If you have questions, reach out to Carrie or I, and we can make that more clear. You should have got an email with very specific instructions, and then we would like to have back when you do training, how to go and who'd you train, and congratulate you on that work. I never want to turn somewhere or ask somewhere in Kansas at a hospital meeting if anybody's heard of post-birth and they all shake their head. That should be gone. So this is our next piece. The rollout continues. Wonderful. Michelle, now, not Michelle. I'm stuck on Michelle. Tiffany, if you could go, let's see, go one more forward. I think that's the blood pressure cuff. Yeah. So some of you have reached out to me about that are not in our pilot group of those hospitals working really, really fast to get blood pressure cuffs in hands for free to patients so they can identify themselves and come for care. Timely treatment begins, right? But for those of us that are not in that pilot group, the idea of getting blood pressure cuffs in your offices and in your hospitals, we have a work group meeting coming up next week. I will send out updates and get you all posted on that once I hear some more. But we're working with the DMEs and the payers, Blue Cross Blue Shield, Medicaid, et cetera, to get more cuffs in hands if your providers want them there. All right, now I think we've hit most of the slides, and I would love to have just a few minutes of open mic if there are some questions or concerns that I can address. Otherwise, happy to answer chat questions for a few minutes. Tiffany, you want to go all the way to the end with the dates and links, please? Yeah, perfect. So next learning forum, you all, is a statewide. Um, Christy, I see your question. I'll answer it. Thank you for asking that. So the learning forums are in front of you. Of course, May will be in person, but the one in March is a statewide learning forum. And then June, August is there too. And then again, you will get the registration information and flyer as soon as we can get it out to you. What can you bring? We will be sending you specific requests, but quite frankly, it's really just if you have specific questions about a protocol, like Carrie mentioned, the breastfeeding or hand expression or pumping protocol. If you still are not sure that that's it, or you have some questions or tweaks, you're welcome to bring the physical copier on your laptop. Transfer protocol, same conversation. But in terms of specifics, at this point, no, we don't have anything that you need to bring with you. Our goal is that you would meet with those groups that you are not a 5 on, that you haven't completed, or to sit in think tanks of maybe a higher functioning hospital with a hospital that's struggling, and to do some brainstorming around there. But regardless, nothing specific. Also, you'll notice that we ask for your t-shirt size when you register. Man, I can't wait to show them. Tiffany's team has come up with a great graphic. I'm a t-shirt girl, so I'm excited to show that to you all soon. But one t-shirt per hospital will be our goal. We hope to be able to provide more in the future, but that's why you're asked your t-shirt size. Okay. How is everyone getting their documents to complete the online education regarding post-birth warming? Caitlin, I think what you're asking is we'll call it the roster of when you train. Let's say that there's 20 people that you train, and then the one that we sent you, the template. Are you asking how to submit that back to us, or are you asking folks how they're collecting that information? Doctors, how are you getting doctors? Am I understanding your question?
Um, like so I tried to get our doctors to do the online education in the clinic side, and just getting major pushback on how they feel they don't need to do it. So I was curious if anyone else is having issues with that.
Anybody can speak up, but the answer is yeah, feed them. Jackie has learned the trickery of feeding providers. Um, it has to be mandatory, right? So you need a physician champion to probably tell them it's mandatory, or it's embedded in their continuing ed that's required. But I will also tell you that the the most important piece is to ask them if they understand what post birth stands for. And if they don't, and the patient says, I called because I see something on my post-birth magnet, they're going to not look so amazing in that moment. So part of the conversation is you just got to know what our patients are being educated about, and sit, eat some pizza, do what you need to do, and go through it. But it's really about the provider champions and it becoming mandatory.
And Caitlin, I don't know if you've gone, I don't know if the clinic nurses have gone, but grab those nurses and get them to come with their providers. I think that helps, and talk to that clinic manager and make sure their time is blocked out, and really get the clinic manager, like I said, like Tara said, it's an expectation. I mean, that this is what you're going to do today. It's no different than the 3 days of Meditech training we're doing right now. Those schedules are blocked out. Yeah, Dinah, roll your eyes there, Tara. I saw it. Those schedules are blocked out, and their nurses are coming. A couple of the nurses are coming with them, and that's the only way we got buy-in as well.
Thank you.
All right, you guys. I think I'll give you seven minutes back. You're doing great work. Wonderful to hear and see you today. And we will see you in March. Questions before that, reach out to us. We look forward to talking to you soon. Have a great day.